Order, order. Welcome to the second session of the Community Mental Health Services Inquiry by the Health and Social Care Select Committee. We've got three panels for everyone to be watching today, but at the very top of our panel is a tradition that we are developing in this committee, which is to have experts by experience, the people most affected by these services start, so that we can all plant in our minds why we're doing this. So for the benefit of everyone watching, can I ask you both please to introduce yourselves and who you are, who you work for, why are you here? Perhaps starting with Elizabeth?
Yeah, absolutely. I'm here because I'm Eve's wife and I've supported her through her bipolar diagnosis and journey so far.
Yes, and I'm Eve Mair. I work at Bipolar UK as Senior Public Policy Officer. I got diagnosed with bipolar when I was 19 and I work to try and advocate for specialist care and for decreased delay to diagnosis for people with bipolar as a consequence of my own journey.
Lovely. Well, thank you both for being with us. I know it's intimidating in here, but it's so important that you're here and I really appreciate it. We'll start with Paulette Hamilton, please.
Good morning, both. Can I go directly to Eve for my first question? What I'd like to do is ask you, could you start by taking a few minutes just to go through your experiences, both of being diagnosed with bipolar affective, is it bipolar affective disorder?
It kind of depends on, there's lots of different kind of phrases. Sorry, you can kind of do that. It tends to be kind of just bipolar disorder, I think.
Right, bipolar disorder. But also your journey of how you accessed treatment in the mental health services.
Sure. So I was diagnosed with bipolar when I was 19, like I said before. I had, prior to that, experienced periods of low mood my entire adolescence, something that is relatively common with people who later get a bipolar diagnosis. When I was about 15 or 16, I went to my local GP and I was prescribed antidepressants. However, antidepressants and SSRIs are actually a huge exacerbator for people with underlying bipolar. So when I was around 16 to 18, I started to experience these periods of high mood, increased energy, and during that time, they were actually relatively beneficial to me in a way. That's when it's complicated. These hypomanic episodes, they kind of helped me in a strange way. But with that then comes an escalated version of that height of the high mood, and it worsens and it becomes more severe as time goes on whilst untreated. When I went to university, I started to experience really low mood, and those high moods started to worsen again, and they became more intense, more scary. And I started to realise that I had the awareness and the insight to be able to know that those moods weren't necessarily normal and that they didn't align with what is generally diagnosed as depression. And it got worse and worse. And I kept trying to access help, I think, during that period of time. So I'd go to my GP and had some quite shocking experiences in primary care in terms of the rejection of the idea that there might be something beyond depression. I'd turn up at A&E and be given sedatives. It was kind of like you got treated a little bit like I think a woman in the Victorian times would be treated with hysteria. It was kind of like there was a sense that what you were saying was untrue or baseless. So there was it felt like there were these barriers constantly to getting help until it escalated so radically. I was 19, I was interning at a newspaper, and I started to experience quite severe paranoia, and I was very, very unwell. And so after having tried to access care and try and access a diagnosis, knowing full well that's probably what it was, having the insight to be able to know that, I then had to go private. So I got a private diagnosis, which cost a lot of money. I was a student at the time. And from there I was given medication, but then I think that's the main thing in terms of this journey is there's a huge delay to diagnosis for people. It's 9.5 years on average in the UK. There's 1 million people with bipolar as well, so that's pretty significant. But then after that, you're not necessarily put into any kind of pathway for care. So there isn't a specialist pathway for bipolar, full stop, even though the condition itself is pretty intricate, very treatable, but half of it is self-management. So you either end up, you're kind of in free fall, you're not actually put into anywhere. You might get put through your GP, who then might choose to refer you on to EIP services, so early intervention in psychosis services. But those services are only for people experiencing psychotic symptoms. So you've got vast swathes of people there who aren't getting a diagnosis through the NHS because they can't access a psychiatrist. You can't, and they're getting a private diagnosis, they're left in the wild. And if they're really lucky, might get put through EIP services, which are really, really great, but they don't necessarily address the core problem, which is that bipolar needs specific treatment and specific self-management, such as sleep, avoiding drugs and alcohol, in order to be able to maintain your wellness, I suppose. So that was my kind of journey. It felt like there was constantly barriers, and then there was no continuity of care afterwards, I think. I had real pockets of excellence in GP surgeries. I had a mental health nurse who was incredible when I lived in Peckham, and that was probably the period where I was the most well, was because I had somebody who knew what I'd experienced, knew my journey, knew that I had insight and could provide insight into when I was becoming unwell, and therefore accordingly get me maybe a one-off appointment with a psychiatrist to do a medication review. But there's never been continuity of care for me.
So thank you for that. That is really insightful. So following on from what you've just said, which what's hit me, it's a bit about no continuity of care, especially in 2025. I'm not sure what year you went through this, but I'm hoping that it would be slightly different today. My follow-on question would be, you work for the charity, the national charity Bipolar UK. What similarities have you observed between your experience and those of the people that the charity actually supports?
Yeah, sure. So, I mean, that's what's really funny about working at this charity, is it's quite an interesting process for me emotionally in a way, because you start to realise that those experiences where you felt incredibly isolated are mirrored in literally everybody. So the delay to diagnosis, like I was saying, is a huge and significant thing. That's for a mix of reasons. It's because a lack of awareness in primary care of the symptoms, and a lack of kind of screening for high mood, the prescription of antidepressants worsening and exacerbating that, a lack of access to psychiatrists, that's another huge thing, and then eventually that lack of specialist care. And these things all together have created a community of people who really, I think, are completely lost within the system. They feel alienated, distrustful, I think, of services because of so many persistent kind of disappointments. I think something that's mirrored constantly with people is that they cannot get access to care until they are in crisis, and that is not okay or acceptable now. Like, people have a diagnosis and they know what they have, they know how to manage it, and they know what they need often. I think people are often treated like they don't know what they need, and they do. And that is a huge, huge issue. You shouldn't have to get to a point where you are going to be sectioned before you get any access to help. You shouldn't be at a point where you become suicidal before you access any care. And that is, I think, at the heart of what I see in our charity, in the work that we do, is we are persistently seeing this alienation that is just, it's really, really endemic, I think. And it's 1 million people. And on top of that, then you've got 5 million people impacted by bipolar because they are loved ones or they're carers or they know someone with bipolar and it impacts their life. And that's a huge swathe of people to be going through this pain that just, that alienation that causes so many problems later down the line.
Can I say, you've explained that extremely well, but what I'll do now, I'll hand back to the chair because people will ask you more detailed questions. But thank you for that. Brilliant start.
Thank you, Eve.
Chair, over to you.
Thank you. Can I ask a quick follow-up of you, Eve? You talked about your NHS journey, but as we know, very often it's more than that, isn't it? It's also housing and finances and other stuff that happens as a consequence of the diagnosis. Have you engaged with other services to help you through some of that? And if you haven't, what are the experiences of others, and what kinds of things do they need that may or may not exist out there to help them?
Of course. I mean, personally for me, I feel like that's something that does get forgotten, I think, in the conversation around severe mental illness in general. You know, the physical implications of mental illness are huge. Medication is massive. Antipsychotics are prescribed really widely for things like bipolar or schizophrenia, psychosis, and things like weight gain are massive. I think people with bipolar die 15 to 20 years on average earlier. I think in primary care that isn't always, it's again luck of the draw, it's a lottery as to whether you are going to get somebody who is kind of persistent, whether they have the time and the resources to dedicate to blood tests that are routine, to checking in on making sure that your physical health is, you know, as good as it can be. In terms of the experiences of other people, I think, yeah, housing is a massive thing. Obviously, work is a huge thing. We're having a conversation at the moment, you know, around PIP and around that matter, and it's obviously incredibly important for lots of people who are struggling with mental illness. Getting access to those sorts of things is really important, but also having workplaces that are suitable for people with mental illness, that make adjustments that are reasonable as per the law, you know, are really important. And often, I think that is something that people aren't necessarily aware of as employers. In terms of services, I think that that's a real missing point, is that this holistic approach that is necessary to understanding the whole person, and the fact that they are not just one illness or a health case, they are also a whole person with a job, a life, a family, a house that they have to maintain during these periods of difficulty.
Thank you. Greg Stafford.
Thank you very much. And Elizabeth, obviously you've been through this journey with Eve. What's been your experience as someone who's been supporting someone with bipolar? What are the good things, and what could be improved for those people who are helping and caring and supporting?
Yeah, I think if I was to try and sum it up in one word, I think lost is a very clear one to me. It's quite confusing, that system, that when Eve got diagnosed, we'd spent such a long period of time trying to find what felt like the truth, or a diagnosis, something that made sense for her, for what she was experiencing. And once you received that diagnosis, I felt initially relief, because I thought, fantastic, we understand what's happening here, there will be treatment plans, there will be support. And then, kind of as you said, it felt like we got cast into the wind. I had no understanding of where to go when Eve became ill. I had no understanding of how to help her. There was no education for me. I had to educate myself and use charities like Bipolar UK and the resources they provide to gain any kind of understanding of what she was experiencing, what she could experience. And I think, yeah, that lost feeling very much came from, if she became ill, where do I go? There was no continuity of care. There was no clear kind of clinician or kind of support system in terms of where do I go if I need to support and advocate for her, especially when people have a mental illness. That can sometimes mean that they don't always understand that they are becoming ill. I think as a partner, as a wife, anyone that's supporting someone with an illness, sometimes you spot these things before they even do. And there is a point of interception, or there could be a point of interception, where I'm expecting that. There is a lot of self-management that can be done to ensure that we don't reach crisis point, or we don't reach that high or low point. And there's nowhere for me to go, or for you to go, it feels, to receive that before it becomes crisis point. So at that point, your options are 111 or A&E. And if you don't really, or my experience is that if you don't reach any of the criteria for sectioning, is that they then get, released back, essentially almost into kind of my care. And as a partner, that's a lot of pressure, because with no education or explanation other than what I've done myself, we're having to work together to make sure that we're able to keep you well without the support of medical professionals at this point.
And over the time that you have been in this role, as it were, forget the terminology, have you seen any improvements? And I think Eve talked about pockets of excellence.
Yes.
Have you, from your perspective, seen pockets of excellence that you would like to see rolled out or expanded?
Yeah, absolutely. I think for me, the key thing from my experience is that continuity of care. I think especially when we talk about mental illness, that trust that you have with someone that you know is incredibly important, especially when you're experiencing some of the symptoms that may come with something like bipolar disorder. But it's also that ability to have a port of call. And I think you referenced Kate, who was your mental health nurse in Peckham, who was fantastic. And it became a consideration, to your point, Layla, about housing and things like that, in terms of where do we live, because we want to keep that support. Like, we didn't feel like, and we have since moved out the area, and as a result you don't have that support anymore because it feels like a bit of a postcode lottery. So for me, continuity of care and having that port of call, and I think support for those that are supporting as well, is really key. I think I've seen, I mean, maybe a crude comparison, but I've seen family members go through physical illnesses, and I've never kind of been at a point, you know, that's very, very scary when someone you love is ill, but I've never been at a point with that where I've been like they've been in the right hands, they're receiving the right care. What that outcome might be, unsure, but we are working to the right pathway. I think what I've seen with Eve's diagnosis and Eve's bipolar journey is it wasn't that she was in the wrong hands, it was that she was in no hands at all. There was no support there.
Thank you very much.
Thank you. So, I mean, we're here to try and make recommendations to primarily NHS England and also the Department for Health and Social Care. If you could reimagine the world, having had the experiences that you've had and knowing what you know of others, what would it look like? What would good care look like for you guys? Maybe I could start with Eve.
So for me, it would be that from, first of all, access to psychiatrists early on. When people start appearing in primary care with high mood, they are given access to a psychiatrist for a full psychiatric assessment. Once a diagnosis is given of bipolar specifically, that they are given care that is specific to the condition, which, like I said before, does not exist. A specialist care pathway is absolutely imperative with bipolar. It doesn't exist. There is no specialist care. There's pockets of it within universities and services. There's one for young people, there's ones in, that are in across the country, but they are not NHS wide, and every single person with bipolar should be getting access to a service like that to prevent them from experiencing this grief that is the loss of years of your life. Like, that's it, is you lose out on so much because of this condition that you don't have to lose out on. There's so many people with potential and promise that are unable to fulfill it. And I think that is the key to it. It's having people at every level, primary care, secondary care, who understand the condition, that there's specialist care at the other side of it, and that diagnosis is done more efficiently, quicker, and with the empathy and care that everybody with a mental illness deserves to have when going to receive care.
Thank you. And Elizabeth, from your perspective as the carer, do you like that term?
I'm
supporter.
Yes, I'm a supporter. Yeah. You're not in a position where you need a carer. I'm just a supporter in your journey and what you experience with bipolar. But I think I've said continuity of care a lot, but I think it's incredibly important, especially when people are in these vulnerable points, that they have that continuity of care and the understanding of what bipolar is, because I think that's something we've faced a lot as well, is you may have professionals who have a general understanding, but actually understanding what bipolar is sometimes I find myself explaining it back, which kind of feels a little bit bizarre. So I think that clear pathway, because when you got diagnosed and we asked what next, there was no answer. There was no, this is what happens now. And I think when you compare it to many other medical conditions, that would not be the case.
We've got a whole round. You guys are soliciting lots of brilliant questions. So Greg and then Joe.
Yeah, just to come back, obviously this may be beyond the scope of your expertise, but would you say that this is a specifically bipolar disorder issue, or is it a mental health one wide, or are there other mental health disorders or illnesses that are treated or where they are getting it right, that perhaps bipolar diagnoses could mirror and use as best practice?
There definitely is. So those EIP services, like I said before, they treat schizophrenia and psychosis so effectively. They're rolled out basically across the country, and they are so efficient at what they do. Why this is a bipolar specific issue is because there are treatment pathways for schizophrenia and psychosis that exist. There's ones for eating disorders across the NHS as well. But it's because these conditions are specific. And I think there's a kind of treatment of mental illness that we treat... that we don't treat the symptoms, we treat like the overall, but actually there's certain conditions where you do need to treat the symptoms, where you do need to hone in on it, and bipolar is one of them, psychosis is one of them, and eating disorders is one of them, because they manifest in such specific ways that are so treatable. So but at the moment it is a bipolar specific issue only by virtue of the fact that it doesn't exist yet. The problem is obviously wider, but yeah.
Thank you.
Thank you. A question for Elizabeth, actually, just spontaneously that came up. I can understand why you don't want to be called a carer or referred to as a carer, but do you find that happens by clinicians or others within that world?
Yeah, I think it can be. I mean, there are points where I have to be an advocate for you, as I'm sure anyone who has supported someone through any form of an illness, you are an advocate for them. But it definitely feels like sometimes there is a reduction in your capacity when you have capacity, and can have full autonomy of your care, that I am just there as a supporting part. I'm there to understand what the recommendations are, how do we make sure that we implement them at home. Like you said, especially for bipolar, there is so much that is self-management, like you mentioned, sleep and routine. There's a lot of things that actually, alongside things like medication and talking therapies, can be incredibly effective. And that's what I see myself as a supporter. I want to understand what those things are so we can be sure to implement them at home to keep you well, and ensure that you're living, life to the absolute full. But sometimes it does. It's kind of polarising. It's either that I'm not included at all, or that some of that autonomy is kind of taken away from you and handed over to me in some ways, which can feel quite patronising, really.
In terms of terminology, error is not a word that's pushed or used too much. You don't feel that... Because I know in other settings, say for frailty affecting older people, error is a very often used term and people don't like it, understandably. I was just sort of wondering whether that's used a lot in your joint experience or not.
I haven't found it used so much. No. I see I think it's seen more as like a community support, because it's not just me, it's your family, it's your friends as well. I might be the person that you live with, that Eve lives with, but there's, a much kind of wider supporting circle.
Okay. Thank you. Paul Hamilton.
Right, mine is quite a quick question. As I said, the continuity of care is what concerned me, and you've highlighted it over and over again. So if I ask both of you quite quickly, in your role as both someone living with an illness and as someone that works for Bipolar UK, what would good continuity of care look like for you?
So it would be routine. It would be routine access to a psychiatrist. So as part of also seeing a primary. Someone in primary care that took care of the physical. You'd also have access to a psychiatrist relatively routinely. I don't know exactly how frequent that would be, but I imagine every 3 months would probably be an ideal, just to check that your medication's okay, that you haven't experienced periods of mood, and that is just a routine part of your calendar, that you have, okay, I've got my GP appointment and I'll be doing my bloods here, they'll tell me about this, and then I know I've got my psychiatrist appointment here, I'll be checking in there. That is, to me, what good continuity of care is. It's just persistent access, just access to generally anyone.
And Elizabeth, as somebody that supports your wife going through the bipolar journey, for the sake of the discussion, what would good continuity of care look like for you, so you would feel more confident with the services out there?
Yeah, I think it goes back to the point that I made where when Eve was diagnosed, I would go, okay, what next? What's the plan? And there is none. And that to me is what continuity of care is. What is the plan and how do we stick to it? And if it needs to change, who do we go to? You've got a clear port of call to discuss that with.
So my last very quick point is, and if I've cut in with anybody, I really apologise, but it's a bit about, is it that Eve is not looked at as somebody who, as an individual. So package is like an individualized, personalized way of looking at her journey.
Yeah.
So like a baby, when a baby's born, they get a red book. They know what the weight and everything for the baby, and that carries them through for the first 5 or 6 years. I may be wrong, I'm a bit out of date. But is it something like that? You feel that services are broken, people don't know what's happened
and every time we present for any form of support, you have to start from scratch. You have to explain everything that's happened. You have to explain the diagnosis, how long ago it was, what medication we've tried, what medication you've been on. That's exhausting, quite frankly, and especially if you're presenting at a crisis point.
Yeah.
I dread to think what it's like for people who live with bipolar that do not have support, because if you have to advocate for yourself in that way, I just don't know how you would achieve effective support. But it is exactly that, is that it's broken. Every time you present, it's to someone new who has no understanding of any part of this journey, no understanding of the treatment plan or the experience, and you have to start afresh.
Thank you for that. Can I hand back to Glyn?
Yeah, thank you for sharing your experiences today. You said that there's 1 million people with bipolar a year, which would suggest that the average GP sees about 30 people a day, so they'd probably see kind of, 4 people or so who have bipolar every week. I guess, to me, the thing that I'm trying to get a grip to is you had to advocate for yourself on your journey. Is that universal? And, as GPs are usually the front door for our health service, how could they be more acutely aware of the potential of bipolar being a diagnosis?
So I think when people, obviously antidepressants are prescribed really widely. I think it's 8 million prescriptions of antidepressants in the last year. When people come in with episodes of low mood, I think all GPs should be given the kind of tools of the awareness to be able to say, have you actually experienced any high mood? Have you experienced any of these things, these symptoms, like lack of sleep or increased energy? And if so, there needs to be a more kind of rigorous look at the prescribing of antidepressants. So it starts with that kind of education from GPs, and that again is like very luck of the draw, isn't it, in terms of how knowledgeable they are of mental health, the training that they've had, and again the awareness of something as specific as bipolar.
So a very simple kind of thing within the GP training pathway, one would assume, is that kind of, this is the flowchart you go through when someone presents with low mood. Exactly.
It would be it could be as simple as that it's literally almost like a screening.
Thank you.
Yeah.
Thank you.
Jen Croft.
Thank you, Chair. And I'd just like to pick up on, you say every time you go for support, you have to start again from scratch, which is exhausting. Has that ever put you off accessing support? And is there evidence that other people might think, I'm not going to go and access this type of support because I'm going to have to go all the way back to square one?
I mean, for me, it has massively. I've almost got I've developed a bit of a phobia, I think, of doctors, even for physical health conditions as well. There's become a thing for me where, and also recounting those things is really quite traumatic. I wouldn't speak about them on a day-to-day basis with anyone other than probably a therapist. So going and speaking to a medical professional and advocating, and also that thing of not knowing if they understand what it's like or understanding what the next path is, you start to feel incredible alienation, and I think that's routine amongst everybody with this mood disorder.
Thank you, and I can speak for myself. I have bipolar, so I have a very, very similar experience. So I'm one of the 40% that's in employment, and good job as well. So thank you. Thanks for being here.
Thank you, Jen. Ben Coleman.
Thank you. You struck by a couple of things. You said you talked about continuity of care, but it struck me that it's more the absence of care in the first place. And that's right, is it? And the second thing is that when you talk to people in the health services and you say to them, I'm going through this again, I've talked to 6 people, do they come back to you and say, yes, I know this is a problem, but we can't do more because of ABC? And what are those things that they say that are inhibiting them from doing more?
Absolutely. I think in a primary care level, it's that in secondary care they won't accept referrals because people aren't essentially suicidal. That seems to be a really common thing that people are experiencing now. We work with clinicians as a charity, and we hear back from them that they constantly trying to refer people to services beyond them, and that's what they're hearing back, that there isn't they don't meet the criteria, when these people really, really do. And they're just going to end up in crisis anyway. But you're right, it is, yeah, definitely.
Because they feel that you have to, they're saying to you, we only going to get a response if people are in absolute crisis.
Absolutely, yeah. And
nothing preventative
nothing preventative about it. It's all reactive, I think. And proactive care is a fantasy, I think, for people with bipolar. It's like, yeah.
Thank you.
I think that brings us to the end of a very rich half an hour. Guys, thank you so much for coming.
Thank you. It's been a pleasure. Thank you so much.
Absolutely brilliant. Thank you so much, Eve and Elizabeth. And if I could ask the next panel, please, to come up, we'll crack on. You're very welcome to stay, and please do.
Thank you.
Second panel. For the benefit of those watching, may I start by asking you to introduce yourselves? May I start with Steve, and we'll move across like that.
I'm Steve Forsyth. I'm a mental health nurse, general nurse, and representing the Queen's Nursing Institute as a fellow.
Thank you.
So I'm Emma Tiffin. I'm a GP in Cambridgeshire, and I have a number of hats. So I'm the Associate Director for Mental Health and Learning Disabilities for my ICB, and I'm also the National GP Advisor for the Adult Mental Health Team for NHS England.
Wonderful. Thank you so much.
And I'm Dr. Lade Smith. I'm a consultant psychiatrist, clinical senior lecturer at the Institute of Psychiatry, Psychology and Neuroscience. And I also work as a forensic psychiatrist, and I am here primarily because I am the president of the Royal College of Psychiatrists.
Thank you all. Starting with Jen Craft, please.
Thank you, Chair. We've just heard some really interesting testimony from the previous panel, and I think drawing on that, if we can start with what the sort of barriers are to GPs, and Emma, this is probably primarily directed at you. What barriers from your perspective do you see for GPs to enabling people to access community mental health care, and specifically people with a serious mental illness?
Yeah, so I would say that bipolar is on our QOF severe mental illness register, so we do know who our patients are. I think a lot of the problem then is around what we do to support, so big thanks to Eve and Elizabeth for pointing out, I think what's been a problem for years. I mean, we have done a lot, so my main experience on the ground would be what we've sort of done in Cambridgeshire on the back of really the community mental health framework, which was, we had patients with lived experience, Lade and I were on that, looking at what needed to be put in place. So I think, that as GPs, we do need specialist support. So, we have a primary care mental health service that wraps around our PCNs, so it's locality based, and that provides predominantly our sort of specialist mental health expertise for patients like Eve, and that's there, so waiting times are quite good. I think that there's also a big sort of issue around, so it was interesting that Eve talked about, it isn't all clinical support. You don't always need a psychiatrist. It's around that whole recovery, resilience, well-being. So what we've done again is implement a sort of digital solution supported by a face-to-face team around supporting our local population in terms of activities, well-being, and we have a lifestyle medicine approach. So it was interesting, again, hearing Eve talk about sleep. We now have that reaching in. Trish is here, who's our Hey, how are you expert, and that also reaches into our inpatient wards to look at sleep, appetite, exercise, social connection, all those things that are so important. So I think as GPs, we've struggled over the years, I've sort of been busy putting that in place, but obviously there needs to be a much more consistent approach nationally around that. But I do think that quick access to specialist expertise for us, obviously I have a lot of mental health background, some of my colleagues don't, so training is an interesting one. And in my era, you chose between psychiatry and paediatrics. I chose psychiatry and others chose paediatrics, so it's a movable feast, so we do need to do something around that whole training. But if you've got a specialist mental health function behind general practice, core general practice, then you know that your patients with more severe mental illness will be supported, all those needs, as well as that sort of community offer. But I don't want to hog the session because I would talk for a whole hour. Can I just add one final comment about physical health? So again, I think that's really important. You know, patients die 15 to 20 years earlier, tragically, if they have, and others too, actually, with more mild mental illness. So having a really robust approach to physical health is essential. So we do have a team that offers annual reviews. So Eve's point, really important. That needs to be, some of that has been done nationally, but that approach to a robust, including a medication review, because antipsychotics cause weight gain, metabolic dysfunction literally overnight, within 6 weeks. You just see it go like that. So unless it's monitored, and Lade will talk about patients with more severe mental illness, that I think that's really important to have in place. So that is a review. I don't think it always needs to be a psychiatrist. We haven't got enough, but we can look at other ways of delivering that.
Thank you, and I think we always have people that can talk for a long time on our panel. It's one of the joys of this place, and I wouldn't want to stop you either, because we're here to tease out what's coming out of that. But I will just address the next one to Lade and Steve. How can the government and how can we, sort of, as policymakers, improve access to community mental health services for people, again, with serious mental illnesses? And what kind of policy interventions do you think the government should make, whether that's sort of looking at statutory interventions or guidance or even improved training in the primary care network?
Perhaps I could start. I do think there needs to be a little bit of history. First of all, everything that Eve said is absolutely spot on. There's only one area I disagree with her, which is it's not just bipolar illness. Mm-hmm. So this includes all severe mental illnesses. That's people with severe and enduring psychosis, like schizophrenia, bipolar illness, and also actually including people with severe anorexia and eating disorders. Mm-hmm. We know that, and people remember that for many, many years, hundreds of years, we delivered the majority of mental health care in inpatient services. It was an asylum-based system until about 40 years ago. And at that point, previously, 40 years ago, we had 154,000 beds. We reduced our beds to 87%. We now have about 18,000, 19,000 beds, and we deliver the majority of care in the community. However, unfortunately, the money that was needed to make sure we had good community services perhaps didn't follow as well as it could have done. It's not been used as efficiently and effectively as it could have been. Mm. So we have a situation currently, there's been work done recently. Colm Owens, who's Medical Director in Devon Partnership Trust, has done some modelling work, and using NHS data, showing that essentially in England there are about 1.3 million people with severe mental illness. But we only have capacity to provide care to about 560,000 of those people. Which means that if you have only the capacity to provide care to 50% of people, it means that 50% of people get good care and the others don't. I think someone said there was an absence of care. Or you provide substandard care to 100% of people. Mm-hmm. And what Eve described very well was the kind of episodic, intermittent approach. What she also described was something that I recognise. I've been doing psychiatry now for about 32, 33 years. And when I started, the care that we provided was continuous. It was continuity of care. You would see a psychiatrist fairly early into your... as soon as you presented, you'd see a psychiatrist. You get a comprehensive biopsychosocial initial assessment that would essentially determine your treatment package. And that treatment package would then be delivered over time. You would have a care coordinator, a key worker who would see you regularly, and that would provide some continuity. And you would also have input from a psychiatrist every 3 months or so. And Eve said that's what we need now. Unfortunately, over time, because of an erosion of the services in the system, we don't have an ability to provide that kind of continuity of care in every single place. Some places are doing it really, really well. Eve described early intervention services, psychosis services that are doing that pretty well, but not everywhere has an early intervention service.
When in time was it good last?
So I would say probably about 15 years ago it was good, up until about then. Mm. And then we started having more episodic approach to services, unfortunately. We had the care programme approach, which was something that meant that you were required, we had rules of practice. We were required to ensure that we saw people regularly, that if someone was discharged from care, that someone would only be discharged from care when they were mentally well and ready to be discharged. If they were discharged from hospital, someone would have to continue to look after them. And very importantly, you were required to be responsible for that person until you handed them over to whatever service it was. And just to say about continuity of care, we know there's good evidence that it reduces hospital utilisation costs by up to 27%, and it reduces emergency department visits by 17%. And it's something that patients want, it's what the staff want as well.
Is this role you spoke of, having a care coordinator, would you see that role as kind of being key for that continuity approach?
Yes. One of the issues that's happened is that we have significant staff vacancies, particularly in the... And care coordinators are usually often nursing staff, but can be other types of staff, occupational therapists, social workers, psychologists, but primarily nurses. And we have, on average, 20% vacancies in terms of nurses. We've got about 15% vacancies when it comes to psychiatrists. But in some places, particularly in the community, we're talking up to 60%, 70% of psychiatry vacancies.
Would a care coordinator, in your opinion, would that have to be a clinical role?
So there's something about, Emma mentioned the community mental health framework. Mm-hmm. So a few years ago, we developed a new model of working, and just to say that it's not all bad news. There are some things that we know, there are solutions that we know would help. And the community mental health framework works such that you use all aspects of what's available to you in the community. So for example, someone mentioned housing, debt, employment support, and you use a voluntary sector. You partner with primary care and secondary care. But many of the people that we see are significantly impacted by their social situation, and it's that which causes them to become unwell and relapse. Now, we can help, as psychiatrists, we can help get people better, but then we send them right back to the conditions that cause them to relapse in the first place. A classic kind of Michael Marmot thing. The community mental health framework requires us to partner with all the different agencies in the community, and when you have community connectors who will support people with their debt issues, their housing issues, etc., so they're less likely to relapse. Emma described having specialist mental health workers who sit co-located with primary care and with the voluntary sector and provide that support, that extra specialist support, which would mean that fewer people actually have to be referred into secondary specialist care. And we know that when it's been implemented properly, it works. In Cambridgeshire and Peterborough, it's worked very well. In Tees-Esk and Weir, in Hartlepool, it's worked very well. Mm. So in Hartlepool, they have found that they have reduced the number of people being referred to specialist secondary care from about 40% to 2%.
Wow.
Yeah, which is phenomenal. It means that people are still getting the support that they need, but they're getting much more of the relevant support that they need in the community. And then those people who do become unwell get referred to secondary care, but we have more time to provide them with the continuity of care and the more thorough assessments that they need and the more thorough interventions. Because the problem is that, unfortunately, care coordination does not necessarily mean that you actually get an actual intervention that helps you to get better. And so that's what's missing.
Thank you. And I think before I hand back to the chair, Steve, have you got anything to add to that you wanted to come in on?
And probably I'll give a view, not as my role as chief nurse, but as a brother to my brother's got bipolar. Mm-hmm. And actually what he would probably sit here and say is that there was multiple handoffs, and to Eve's point, he would often either be in crisis or be not known to services wherever he may be. The only time that he felt and probably felt that it worked better for him was when he was in Wales, and of course Wales have the mental health measure, and part of the mental health measure is that you can refer yourself back into services straight away. I think there's a focus on this being doctor-led, and I think that, and I'm not suggesting the panel are recommending that, but certainly from a committee group there are amazing professionals, not just nurses, but if you remember there were care navigators as well once a time, which provided support, particularly in physical health, to make sure that there was a single point of contact. The problem is the instability in the workforce. So your care coordinator, having been a care coordinator in the 90s, you know, it was a stable job for me. But now, with the cost of living crisis, you see that lots of people will jump and move quickly through the bandings, through Agenda for Change as well.
And is it so a care navigator would be a fairly low-banded role? Is that?
It could be any banded role, so it's around the consistency and making sure that the person, if you look at Dialogue Plus, so moving from the CPA model that Lade spoke to, which created a two-tier of enhanced CPA or non-CPA, Dialogue Plus actually looks at meeting the needs of the individual, because the problem for my brother or Eve will be, and I don't mean to talk on your part, but you repeat your story so many times because you're seeing so many different people, and then all organisations use a different electronic record. Just quickly, whilst I'm on it, so where I work, Rotherham, Doncaster and South Humber, we've set a number of targets. So we've set a target that 95% of people with a severe mental illness, not the QOF register, but determined by our organisation, which increases the people that will be seen, that we see people 95%. So they have an annual health check. But the important bit, and what Emma and I have spoken about previously, is actually that the subsequent intervention, because actually there's about 8 different physical examinations that you'll need to take, and not all of those are always done at the same time, because somebody may have a needle phobia, but it's about the right person doing that with and Dialogue Plus covers some of that.
And is Dialogue Plus, is there a sort of digital component to this, or is it entirely person-led?
It's both.
Both, okay. And both of those being in place is key for it to work. So you wouldn't be able to replace it with entirely digital technology. It has to be a person at the center of it as well.
Yes, absolutely.
And everything. Thank you. I'm going to hand back to you, Chair.
Thank you. That's very helpful. Lade, can I just pick up something that you mentioned? So 15 years ago, something changed. Can you pinpoint what it was that changed?
Well, there were a couple. I think it's not all at once, but there were a number of things that changed over time. There was an integration of health and social care. Mm-hmm. And that meant that, and that took a while. It meant that there was a kind of, how can I put it, a kind of dissolution of roles, and people were a little bit unclear about what they were meant to do. That probably didn't help. There was then a push towards, and this is probably because of resource implications, but there was a push towards saying, why is it that you need to have this continuity of care? And because also there was a working time directive, it meant that people had to, doctors were doing, ridiculous hours, far too many sessions. So for example, when I first started as a consultant, I ran a ward and also ran the community team. Mm-hmm. And it meant that when people were becoming unwell in the community, I could bring them in early and then also move them out of the ward quite early. So I was the person who looked after them everywhere for my catchment area. Mm-hmm. It was decided that really we needed to have a different approach that allowed people to work just the 10 sessions. So you decided to become either an inpatient doctor or an outpatient doctor. Or a community doctor. There was also the idea that, well, not just the idea, but there was also a recognition that certain types of people did better with specialist teams. So early intervention teams were born. Some teams, for example, some areas had specialist affective disorder community teams. There were specialist eating disorders teams. And it meant that gradually over time, community mental health teams became so everyone, of course, when there's a new team, everyone wants to go there because that's where the resources are pumped in. Right. Mm-hmm. So there were a few things happening at the same time. You had to be an inpatient or outpatient doctor. If you're going to be a community doctor, it was like, well, okay, and not just the doctors, but the nurses and everybody else, let's go and work in the more sexy teams, if you like, because, the early intervention teams, etc. And it meant that the people who were left in the community teams, bearing in mind that the more specialist teams had quite strict criteria. Mm-hmm. So, and most people with mental health problems, severe mental health problems, don't just have one problem. Yeah. There's often comorbidity, particularly with substance use, alcohol. Yeah. A good 48% of people with mental health problems have comorbid alcohol or substance use issues. And they're people who are more likely to die by suicide. But it meant that those people didn't fit the criteria, so they'd end up being the ones who are often more complex in the community teams, with fewer people looking after them.
That's very helpful and instructive. Andrew George.
Well, thank you very much. Actually, I was a member of the Health Select Committee 15 years ago, and we look back, I think at that stage, at CAMS, and it wasn't in a very good state. I mean, looking backward then, but anyway, that's probably a conversation for another occasion. I just wanted to look particularly at the issue of integration. I mean, what you've described in relation to the presentation of mental health services 15 years ago, it seemed to be one which is actually relatively well integrated. And from the point of view of those who need, sitting outside, who need the services, and then have to interface with it. Obviously, it's not for them to fathom the internal workings and wiring and plumbing of how everything kind of operates within the service and the administrative and financial arrangements of it. But would you say that the service that we have at present is one which users of the service find is integrated and they can smoothly, if you like, they don't need to use their sharp elbows to be able to get the kind of service that they require. Are you kind of satisfied that that's the case at present?
I mean, for me, if I can, I would say that it depends on where you are. So Lade and I had a conversation, the system, so the framework very much supports the integration, as Lade referred to, with primary care, with our voluntary sector, with specialist services. And some systems have really embraced that and, got quite far. And I think there's various tips. So I think some of it's around, a lot of it's relationships. It really is, if you get on, you know who your consultants are, you know who your key leaders are. We've gone all out on leadership within primary care, so we've now got clinical mental health PCN leads. That's made a massive difference because you find that clinical directors are so run off their feet in PCNs, and not all of them have an interest in mental health. So we haven't just done the sort of champions, we've contracted those sessions, and they interface with their practices, they bring back knowledge of what services are out there, they will feedback if there's any problems with their primary care mental health service, and that's made a huge difference in terms of the patients not being being able to address those problems. I think likewise we've put GPs working in our mental health trust, so we've got GPs working in eating disorders, ADHD now, on the inpatient ward, interestingly, and our long stay ward and our early intervention psychosis, and that's made a huge difference just because it's relationships. Then specialist staff understand what we do in general practice and vice versa. In a similar way, we've gone out the other way, as in we've got the primary care mental health service that are staff employed by the trust and map onto the psychiatrists that bring the specialist support out to the GPs, actually at individual practice level. And our neighbourhood teams have hubs where they discuss patients, usually in an anonymous way. And there's housing, there is the work well people. It's not perfect, so not all our areas have this yet, but we've sort of been rolling it out. They all come, they can bring patients or to our third sector and say, actually, one of our great examples is a patient who had schizophrenia who was kept well by watching cricket on TV, and his TV broke. And the psychiatrist is like, well, what do I do? And I'm like, well, I don't know. What do I do? And anyway, sure enough, it got sorted out at the hub because it isn't rocket science to find a TV for somebody. So those are the sorts of examples, and the creation of, which Trisha's worked on, virtual mental health networks. So everybody, the leads know each other. And I think that's key to integration. And then if people know who each other are in their patches. So I am a fan of neighbourhood teams, as you all have gathered, that local approach. And my GP colleagues all said we yearn for the days when there was a CPN in each practice. We haven't got that. We've actually got a wider solution. But as Lade said, it's not everywhere nationally. So we need to share some of these ideas, and nothing will ever be perfect, but, slowly start to roll out some of these initiatives. But hopefully that, I think the leadership, the governance around integration and those relationships is critical. Yeah, and so the CPN in every practice, as you said, is obviously very... Sorry, community psychiatric nurse, I'm terrible at acronyms. That's right. Yeah. Of course. But as I understand it, that each primary care network is entitled to one
such specialists within each network, up to 100,000.
It's not that straightforward. So they're entitled to one mental health practitioner. And there's quite a broad classification of what that means. And it depends on where systems already are. So for us, we already had, our primary care mental health teams for each PCN. So there's a Band 7 who's a very senior member of staff who will triage referrals. So our wait time's under 4 weeks, even though there's a vast number. And they will also see the complex patients in Band 6. So if that's already there. So we used our practitioner PCN offer around community connector roles, which are sort of social prescribers with expertise in mental health. So for patients that, a lot of social prescribers will tell you they don't, my colleagues sometimes give them quite tricky patients that it is too much. So you need somebody with a bit more mental health expertise. So the mental health practitioner role does vary a little bit, but it has been very helpful, I think, about bringing that whole awareness to mental health and that extra support to primary care.
Steve, from your perspective, looking at it, as far as the community health teams working in primary care, are you happy that those relationships are kind of easy and the integration is well established now?
There's so many different models, and I think that's the point that Dr. Tiffin was making. So we have tertiary services, so we have middle services that interface with primary care, but also then work within the CMHT as well. I mean, a big problem within mental health is the waiting list. And if you ask anybody when they see their GP or see somebody else, they'll want to know when is it that they're going to be seen. So if you're having bloods done and you need to see a diabetic specialist, you'll know when your appointment roughly is. If you're going to see then a psychiatrist or a CMHT, or you need an ADHD assessment, in some parts of the country you can wait up to 10 years for that first appointment. But again, one of the and I have to plug the organisation I work for, because one of our 28 promises is that we will see you no matter what service you need to come into contact with. So we operate wheelchair services, health visiting services, through to a psychiatrist appointment within 4 weeks. So on the backdrop of other organisations, announcing years for waiting lists, at Ardash you'll be seen within 4 weeks, and that makes it really clear to the person who's going to be seen that they have to wait no more than 4 weeks to be seen.
Right. Lade, you gave very good examples of Cambridge and Peterborough, and also Hartlepool in terms of the community mental health framework and where that's working well. That does sound extremely encouraging, I have to say, in those places. But you're suggesting that it's clearly patchy. So what can we learn from the places where it's worked well, and how can that be rolled out, or can it be rolled out to other areas so that other areas benefit from the successes that others have experienced?
Thanks for that. So just to say that the work that Emma and colleagues are doing in Cambridge and Peterborough, and the work that's being done in Hartlepool area, and clearly the work that Steve's doing in his trust, is fantastic. But actually, I need to tell you that that's unusual. Actually, unusual. So they're exemplars. They're exemplars of what can be done. To the waiting time and access standards, when and this government inherited, I think, 9.2 million people on its waiting list. However, I think 7.4 million, this is on the elective waiting list, 7.4 million have physical health problems, and they're being attended to in the elective reform plan. But the 1.6 million people who have mental health problems aren't counted in that. And that number of people is growing. In a year's time, it's going to be 2 million people. There aren't actually waiting time and access standards other than for early intervention, psychosis, certain children and young people's eating disorders, and I think some dementia waiting lists. But generally, there aren't waiting time and access standards, which means that you get places like Rotherham, where Steve works, where they'll make a decision that it's going to be 4 weeks, and they try hard to stick to that. And other places can't make that decision. And so it really is about what the capacity is at that time.
How have they managed to achieve the 4 week?
I don't know. I actually really don't know, actually,
yeah,
Steve. I really don't know.
Tell us, how it sounds amazing. How have you done it?
We've our chief executive, who comes from a DGH, District General Hospital background, has made a number of commitments and promises, and it's a collective approach. So we're going to do that by 2026, and also made a commitment to return everybody who's an inpatient out of our local area, that we won't have anybody out of area as well because of the impact that has on mental health. So we've set 28 really clear promises to our community and invested all of that within and with the community. So so that's why we set the standard that 95% of people with an SMI will have a physical health check against the previous QOF was 75%.
Yeah, 60% plus. Yeah.
Can I just ask, Steve? I mean, if you were transferred, moved to Wales, and then in circumstances where a patient could self-refer, as your brother says was able in Wales, I mean, what impact do you think that would have on your service? I mean, would it actually drive improvement, or would it simply fall over?
So I actually used to work as the Director of Nursing in North Wales, so had an experience of the mental health measure, and there was the ability to, if people were missed within the percentage, they weren't carried in the next month. So there was a number of flaws with certainly with the mental health measure that we're being revisiting. But the ethos and principle of it was the right one, that people should be able to refer themselves back in without having that bureaucratic process of getting a GP appointment, getting an assessment, waiting to be seen, potentially then again, and that's what CPA tried to do. Certainly was that continuity of care. Which is where a number of hopes with Dialogue Plus are we're laying it at the door.
And do GPs kind of act as gatekeepers? I mean, or do they simply respect the request of every patient?
I think it's variable. I mean, that's why we put in place the support. So you ask a really interesting question. So the reason we set up our original primary care service was in 2015 was because of desperation. So we had the biggest referral rate in the country in Cambridgeshire. We had over 16,000 referrals a year, and it was chaos. It was a single point of access. And when we looked at those, 90% were returned back to the GP with all but a minimum of care, of advice, and they were going round and round. So this was crazily inefficient. So how we've got our waiting time under 4 weeks is because we've set up a primary care mental health service that actually does something for our patients and doesn't just give advice. It proactively, and it accesses the community, the housing, we've got social workers in the model, the things that actually our patients need. So I'm not saying it's perfect, but it's made a big difference, and that's how we got our times right down. I mean, ours were months and months, and people were just going round. Eve's point around telling their story for the 55th time in a year, because they so I think for my GP colleagues, the feedback, that's how I judge things, is very favourable on what they now have available and the support that gives. And a lot of it's around social interventions. It isn't medication, but obviously medication, physical health is very important. So we do, those staff are only band 4, so that's a very low. So I would say you don't need a psychiatrist for, much as I love our psychiatrists, but for everything, we haven't got them. So it's looking at different functions rather than form, what we need, and then putting that in place.
Can I just say, actually, it's very important to say that, again, these are exemplars.
Yeah.
The fundamental issue is that in mental health care, we do not have standard set waiting and access times. There aren't these across the country, and they should be. And if there aren't, it will mean that where you've got places like Cambridgeshire and Peterborough, where people really, really care about this and they think about it properly, then something will be done about people particularly with severe mental illness. But we cannot forget that, unfortunately, there's significant discrimination against people with severe mental illness. There's significant health inequality for people with severe mental illness, and they are very easily forgotten. And it should also be remembered that a significant proportion of people with severe mental illness are from minoritised ethnic communities who are doubly impacted. And they're much more likely to access services when in crisis, which means that people are much more likely to end up being detained. Having waiting time and access standards, just in the same way as we do for physical health care, would not only introduce parity of esteem, but it would significantly help to improve and drive improvements in quality.
So do you mean, national standards or targets? Is that what you're saying?
It would be national standards. We should have national standards in the same way that we do for cancer care.
So NHS England is working on that. So there is a 4-week community mental health waiting time for meaningful intervention. So that is happening in their defence, I suppose. But Lade does totally make the right point that everything's at the moment patchy. And there are also standards that are being worked on for community mental health, which are sort of must-dos for patients with more severe mental illness. So those are also coming. So there is some, but it's then about implementation and delivery of those.
But we have known this for a long time,
yeah.
And we have needed this for a long time. There's been patchy implementation of the community mental health framework. It needs to be implemented properly. It works.
Thank you very much.
Yeah.
Dr. Becky Cooper.
Thank you so much, and I absolutely echo what you say. Having been in the healthcare business for 20 years, it's a very familiar conversation. I wanted to go back to severe mental illness and physical health, and I wanted to ask your opinions on, obviously you've outlined that there are severe discrepancies between physical health outcomes in this particular group of people and the general population. We also know, of course, that that is true for other groups of people in our population. So I just wanted to ask the three of you what you think the specific barriers are for this particular group of people and how we might start to overcome those barriers. And I'm sure you're doing work to address that already.
So first and foremost, say that people with severe mental illness, particularly people with schizophrenia, bipolar illness, die 15 to 20 years earlier than the general population. Suicide is very, very common, but it's not the commonest cause of death. It is cardiovascular disease and respiratory disease. And that's partly, there is something about the illnesses themselves that increase the risk, we know that. There's certainly something about people's lifestyle. The medications that we give unfortunately impact in a negative way, so it compounds a problem that's already there. But one of the biggest problems is access to physical health care. So there's the QOF that Emma spoke about. So GPs are expected and incentivised to provide physical health care. Certainly, there's a national audit of psychosis, and that requires, particularly in early intervention services, to provide physical health care. And actually, that national audit's been showing improvements over time, and that's really positive. So it shows that if you are required to measure it, you'll do it. When we're not required to measure it, then people don't do it so well because we're all very, very, very busy. Mm-hmm. And one of our concerns is that in the recent planning guidance, the kind of expectations of providing physical health care have dropped off a little bit, actually. They're not really in there. It's a bit arbitrary. It depends on the ICB. That's a problem because we already know that if you've got severe mental illness, you're not going to get access to care. So if you have cancer, you've got severe mental illness, you are 50% less likely to get treated for that cancer. That's simply discrimination. Mm-hmm. And so we would argue and advocate for the most marginalised people in our society getting the best care. If we design care around the most marginalised group, everybody else will benefit. Mm.
So I think Lade is absolutely right. I mean, there was a target around physical health checks, and I used that in my ICB to haggle for additional funding. So we set up a bespoke service for all patients on our QOF SMI register. I'd love to do more, but at least they all get the annual review you've heard about and a proper physical health check, and that happens in conjunction with the GPs. I think my biggest mantra is don't just screen, intervene. So those staff have the capacity in their job plans to then support patients to access stop smoking, so they know who the local authority services are that commission stop smoking services, smoking cessation, weight management, all those things, and they have that relationship. They go into CMHTs and actually deliver health checks there for patients that really don't engage, where it's tricky to engage. So it needs to be a kind of system approach, but you do need to invest, I suppose, I think, and have quite a specific resource. And my last comment is actually parity seems interesting, and having Lade sitting here, but people, we get slated for not thinking about mental health, not me, because I always do, for the physical health lot, GPs and physical health consultants, but sometimes it's the other way around, and actually our consultant staff or specialist mental health staff don't always think physical health. So I think the stuff that Trish has worked on, putting a lifestyle medicine programme into inpatients and into the hospital and bringing in what's really well-being, and those 5 pillars that the RC Psych sort of devised around lifestyle and what's important has been really, really good. And we're starting to see the shift around a cultural change in the specialist mental health setting, saying, actually, we can do a blood pressure. We are a nurse. We did do that at one point. Weight management. And I'm being facetious, but, it's really important that it's both ways and that there's that whole cultural approach to physical health. So it was interesting hearing what Eve said. And we need to intervene early. 2/3 It's shocking. 2/3 of, it's cardiovascular that kills people, sadly, and 2/3 of that's preventable, and it's not good enough. And we have done some physical health guidance in NHS England, but we really need to then look at levers to get people to engage with that and roll that out. But I'm off on soapbox.
Actually, just to say it, because Emma's right that sometimes in mental health care, practitioners don't feel confident about physical health care, but there's a very good reason for that. A good 20 years ago, there was a thing called Project 2000, Steve will know about this, and a decision was made that if you were to become a mental health nurse, you didn't need general health training. So psychiatrists, we go to medical school, we become doctors, we train in all the other parts of medicine, and then we specialise in psychiatry. Mm-hmm. And the same was true for nurses. Mm-hmm. Nurses trained as general nurses, and then general physical nurses, and then specialised. That decision was made that didn't need to happen. So it meant there was a generation of nurses who weren't so confident in looking after physical health care. Psychologists don't do physical health care, social workers don't know how to do physical health care. And as their roles became more, that there was an expectation that they did more, then we're actually asking people to, it's one thing to say, taking the blood pressure, but actually if you've never been taught how to take a blood pressure, then why would you know how to take a blood pressure? Yeah. That's changing now. Yeah. But, it's not simply because people were being lazy or anything like that. It's because actually they hadn't been trained. And we recognise now that that's a problem. But there is a significant issue everywhere for people with severe mental illness. And it's a real plea, please, could you bring back physical health monitoring into our guidance? Because if it's not there, it won't get done. Yeah.
Excellent. I think that's, a very worthwhile plea. Steve, is there anything you'd like to add?
Unless you're in our dash, because we're going to have 95% of people swim with it. But I suppose to that point, so having been the class of Project 2000 in the late 90s, having 18 months of physical health training, I remember Sister Black on D17 at New Cross Hospital, who taught me how to use a sphygmometer, and I wasn't allowed to leave the shift until Sister Black was content with that. But actually I went back to do my general nurse training for that very reason. So being a community psychiatric nurse, a CPN, actually what I was really skilled at doing was completing benefits forms, to doing blood pressures, referring to the diabetes nurse, engaging with the African Caribbean Community Initiative in Wolverhampton, because I was the care navigator, because it's the reverse. You get too many handoffs when people need a physical health check, because often if it's done in QOF in GPs, the person then has to go and present to the GP, negotiate a receptionist, explain that they need a physical health check, and often they won't continue past that the person who holds all the keys to the access of the appointment at the GP surgery. And again, there's some national deviation. So in parts of Rotherham and Doncaster and South Humber, the GPs actually have allocated the QOF money to our services, so we provide that. In others, they don't, and we really enhance and support the GPs in making sure that people get physical health checks.
Great, thank you so much. I think you've outlined the issues really well and succinctly, and I suppose just going back to what Lade says, the sort of the outstanding stuff that you're doing is fantastic. It's just the lack of standardisation across the country, which I think we're hearing loud and clear, so thank you.
Thank you very much. I have one very final question for all of you. You've got the 10-year plan coming up. What would you like in it? You can have an extra one if you want, because you've been very clear about the targets, so you can have an extra one if you want.
We would really like that mental health care as waiting and access standards. Mm-hmm. There is a recognition that the system, currently as it's designed, is only going to allow us to provide care to about 50% of the people that we need to provide care to. That instead of there being vertical prioritisation of care, so what I mean by that, at the moment, with the elective reform, then everything, the focus is on physical health care, hip operations, etc., which means that it would be quicker to get your bunion sorted than it will be to get your bipolar illness reviewed. So we would prefer horizontal prioritisation of care, and I know that means some difficult choices have to be made, but it should really be about thresholds, and we've got lots of clinical expertise to help you to make those decisions. So horizontal prioritisation of care instead of vertical prioritisation of care, which would mean that people with severe mental illness would hopefully finally get cared for the proper care that they require and need.
Thank you. Emma?
So I'd like to see a focus on community mental health, you'll predict it, and primary care mental health particularly. Physical health, so a bit gutted that, not in the planning guidance. Okay, we'll go the inequalities route, but it's not quite the same. And our third sector, it's so difficult to shift funding pots around. That's one of the really difficult bits. So actually if we have done well with the community framework, it's improved, but, seeing more ability to shift funding streams, because so much of what matters to our patients is stuff we can't do as medics or in health, really. And that's what will have the biggest impact. So your housing, employment, there is actually great stuff going on with Workwell and IPS on that. But, that's what I would like to see. So some kind of ability to shift funding around. And
Thank you. Steve?
So as a nurse, I'd like the Staffing Act to become law, as it is in Wales. But I suppose the other part that I want is Core 20+5 to be really embedded across all organisations.
Thank you. Thank you very much, all three of you.
Thank you.
If we can ask the next panel to come up as quickly as they can.
It's the socio-economic anti-racist term they use called 20+5.
Right, so we definitely have a last but not least panel. So for the benefits of the people watching, please could you introduce yourselves and what you do, starting with Sam, if I may.
Good morning, I'm Sam Allen. I'm the Chief Executive of the North East and North Cumbria Integrated Care Board.
Thank you very much.
I'm Jane Yeandle. I'm the Service Group Director for Mental Health and Learning Disabilities for Somerset Foundation Trust.
And Norman Lamb. I'm Chair of the South London and Maudsley. I used to work at this place for a few years and was Minister responsible for mental health for about 2.5 years as well.
And then after that, you were Chair of the Science and Technology Select Committee.
I was Chair, so it's a bit of an odd experience.
So you're in a different spot, but it's lovely to have you with us. So I'll start, please, by going to Ben Coleman.
Thank you very much. It's very good to see you all. And I'd just like to start. We've got some examples, and we've sent information and submissions of good work that's going on. And perhaps I could start with you, Sir Norman, talking about what's happening at Maudsley with the pilot that you're running on community hub model. Actually, I'm going to ask all of you to just warn you. I'm quite interested in specifically what's happening involving local authorities as one of the partners. I'm going to be asking all of you that because we're talking very strongly and understandably about the NHS side of what needs to happen, but it seems to me there's a much wider requirement. So I wonder if you'd like to talk a bit more about what's happening where you are and about that.
Yeah, well, thank you. I suppose the starting point is why we're doing it. And I actually went back and read the people with lived experience, their evidence to your first session, and of course listened to the very powerful testimony this morning, and you can't help but conclude that the system isn't working effectively for very many people. There are some great stories of recovery and there are brilliant staff working across the system, but the design of the system doesn't deliver continuity of care, doesn't deliver the opportunity to build relationships with people. There are too high thresholds so that you can't get in until you're very sick. We preach the principle of early intervention, but we deliver the very opposite. So it feels to me like there is a case for fundamental change of our design of care system. And so we started to sort of work on developing those ideas. We started to talk also to NHS England. They came up with a plan to invite trusts around the country to trial new models of care. We were selected as one of 6 trusts doing that. We've learnt a lot from Trieste in northern Italy. In fact, I was out there 2 weeks ago. I've got to know a guy called Roberto Mezzina who led the service for several years and has worked in it for 2 or 3 decades, I think. A wonderful and inspiring man. So I'd sort of very much encourage you to explore that further.
We're going, Norman. So yeah, the committee's going to Trieste, and I think
I'd
we're
sort of got an indication that might be happening, and I'm
Yeah.
delighted that you're doing it. And I've been twice now. I went just before I started at the Maudsley, and I found it inspiring. It's a very different culture where people build relationships. There's an open door. It's based around a community centre, which is open 7 days a week. That just doesn't happen in community services in this country routinely. And long opening hours. So, I mean, they call it 24/7. In each of these community centres, there's also about 6 or 8 beds where people can go in a moment of crisis.
That sounds very interesting. Yeah, I'm looking forward to exploring that with my colleagues. Let's say we go to Trieste and come back hugely inspired.
Yeah.
What are the barriers we're going to face here if we wanted to see it introduced? What barriers exist?
Question.
Well, so one absolutely critical barrier is we need to invest in the infrastructure of our community facilities. Because one of the things you'll see in Trieste, I went to Gorizia, which is right on the Slovenian border, a fortnight ago. It's a beautiful place, the community centre. There's art on the walls from local people, not necessarily people with mental ill health, but it's this community space. But I think about our 4 boroughs in South East London, Lambeth, Southwark, Lewisham and Croydon. There are no nice facilities for people with mental ill health in those communities to go to. There are sort of rather dilapidated, locked offices. There are a few crisis cafes, but you can't routinely go to a place in your neighbourhood between 8 and 8, which is my aspiration, and what we're going to do in the trial in Lewisham. And so we need to be able to somehow invest in new smart community facilities.
Are you doing that in your part of the world? Because the funding, is it coming from the...
Funding doesn't facilitate it. So we're lucky to have a relationship with the Maudsley charity. So we're getting support from them and we massively appreciate it. But one of the recommendations I would really encourage you to think about is to allow greater innovation in how these facilities are funded. It could be public third sector collaborations, it could be public-private collaborations, provided we learn the lessons of PFI from the past. But there's a recognition that there's a shortage of state money, so we've got to find innovative ways of investing in community facilities. And that then there is a close collaboration between statutory services and community organisations, and critically general practice as well.
Thank you very much. That's very helpful. I'm going to involve everybody in questions, but that's a really very good and useful start. Samantha, can I just talk about what's going on in Cumbria, the ICS there? How have you worked with other parts outside the NHS, voluntary sector, local authorities, the social care aspects there, to get this integrated community-based support? Is there anything particularly challenging that you found bringing everybody together, or anything particularly innovative you've done which you should be aware of?
Well, I've got the immense privilege our ICB includes Hartlepool, which was, of course, the example that was included in the previous panel. So we're the largest ICB in the country, and we cover 13 local authority areas. So we do work really closely with all of our 13 local authorities, and we're sort of coast to coast, cover the whole of the Scottish border right down to the northeast. And we've been really fortunate that in Cumbria, in the west of Cumbria, we've been able to have one of the 5 24/7 mental health community neighbourhood models, which is very much built on the Trieste model. I'm sure you will come back very inspired. And the work our 2 mental health trusts have been doing with a range of our community and voluntary sector partners and local authority partners has really been about a no wrong door approach, and how we can destigmatise mental health services as well. So Norman's example of using assets in the community, I think is a really good one. And in Hartlepool, and I'd love for you to come to Hartlepool as well as Trieste, we've got the most amazing community asset, which is the library right in the high street. So actually these assets do exist, but it's the will of partners, the vision, and I think the opportunity to come together to say, actually, we're going to give up the ground floor of our library, and that will be our community hub. And when you come to Hartlepool and you're sat in the hub, you won't be able to tell if somebody's having an assessment with an exercise referral coordination service or a specialist mental health worker. It's destigmatising, it's welcoming, it's open. And through the clinical leadership there, and I do particularly want to mention Dr. Ranjit Shah, who I think has been instrumental in having a vision, which is, I think anybody who's worked in mental health services, I've worked in services myself a number of years, will know that the services are not working. The models that we have just do not work. They're not rewarding places to work. And we also know the workforce has dipped over the last decade as well, and Darcy highlighted that in particular. Actually, if we can have a model that enables people to get access to the help they need it when they need it, and if they need more help, and I think particularly Eve's example this morning was really powerful, needing to see a specialist, needing to build up a therapeutic relationship and have continuity of care. And in Hartlepool they found, and I think Lade mentioned, they've reduced the number of referrals going through to the more specialist getting help part of the service from 40% to 2%, which means that that team can provide the continuity of care.
That's very, very interesting. So if you forgive me, I'd like to drill down on what's different, what's happened. Very often the specifics are interesting. May I just, for example, you mentioned the library. Library will be run by the local authority, so I presume. So you've come together as the NHS, the local authority, and you're taking a sort of whole system approach. You're from an NHS background, I presume.
I am from an NHS background.
How do you find it? How have you managed to get? You've got, did you say 13? Which is
local authorities.
Local authorities, which is a huge area. How have you managed to work effectively and respectfully together, accepting that everybody is an equal partner in the game? Or has that been difficult?
I think it's all about relationships, and I think that's been, Rethink identified that as key. And when you go out and particularly talk to the community and voluntary sector, having them around the table in both the planning and the decision making has been critical, actually. And one of our community and voluntary sector leaders actually chairs our main committee around mental health and learning disability planning, which has been quite instrumental. But just to go back to the Hartlepool example, what they decided to do when they got to the point where they said, actually, our services are not working today, we need to fundamentally redesign them. They brought everybody together over a period of a week. So everybody came into the room together and they co-produced actually the model of care. And they've worked really hard over the last few years, because this is also a part of the country that has sometimes been on the map for the wrong reasons in terms of quality of care and issues, but the Trust has worked incredibly hard through building trust in an open and transparent way and saying we need to redesign these services together. So we're not doing to people, we're doing with people. They've also shifted resource out into general practice. Mental health pharmacists is a good example of that. So giving up some of the resource that people were trying to access but couldn't always access, and getting it back into primary care in a place and located in a way that can work alongside general practitioners.
Interesting, and I know a bit of how these rates, and I think they're extremely interesting. They've been through some challenges over the years, but it's great to see that happening. Also great to see the statue of Harold Wilson when you come out from the station.
Yes, yeah. The one thing I did just want to mention, though, what's different about our area is deprivation and the impact of poverty. So when we think about the challenges on services, and and I know this inquiry is focused on adult services, we're seeing at least a 3% increase in referrals year on year. For children, 12% increase. But areas of high deprivation, inequality and poverty, and the distress that comes with that is really significant.
The argument you're making there, I guess, and forgive me putting words in your mouth, is that it should be a universal service, but which focuses more strongly in certain parts of certain groups where the greatest poverty or the greatest need.
Absolutely, and equity, and recognise that there will be some parts of the country that do need more resources, not always health resources, and in fact, mostly not health resources, but other types of resources, housing, really key, the education, and therefore the multi-agency approach being absolutely instrumental.
That's really helpful, thank you. I mean, Jane, can I turn to you? And you obviously have experience of implementing the community mental health framework in Somerset, and Somerset's come up a lot of praise. Why do you think that it's seen as such a successful example of implementing the framework? What's it that you've done?
I think there are a number of things. I mean, I would say that a good deal of the success is down to the fact that right from the outset we've co-produced the model.
When you say co-produced, I'm going to be a bit.
So co-production.
What does that mean to you? Because it's often a word that's used.
What it means to me is where you've got experts by experience working alongside experts by learning to design and improve services.
And how did you get people to agree to co-produce and to listen to the people that they were working with?
We don't always agree, and I think that's quite healthy. We had experts by experience kind of involved in our service improvement anyway. So we have a pool of experts by experience, and we asked them if they'd like to be involved in the community mental health transformation work. So they were there, I think 3 or 4 days after we knew we had to submit a bid.
Why did you do that? Why do you think other people don't?
I think my sense is that people do, not everyone, but I think co-production is something that lies at the core of many mental health services, and you do that because if you design services around the needs of those who are using it, you're going to probably design a good service. So co-production's been really important. I think the other thing I'd want to highlight is the partnership that we've had with the voluntary sector, with Rethink as the lead accountable body, with 18 voluntary sector organisations now working as part of that alliance. And why that's important is it's creating a sustainable voluntary sector within Somerset. It means that we're able to use local assets, because some of those voluntary sector organisations are ones that you would recognise at Mind and Rethink, but some are very specific to Somerset. So, it's a big geographical county, terrible transport links, so we do need those voluntary sector organisations that reside in those localities.
That's very helpful. It's interesting you mentioned Rethink. They've said that the government of the NHS should commission a national evaluation of the community mental health framework. What do you think? Do you think that yes to that? And do you think commissioners have enough evidence and guidance to implement the framework effectively?
I think the guidance was incredibly helpful in terms of principles and visions and values, but I would agree with other panel members that it hasn't been universally applied and that there are various differences. So I think yes to a national evaluation, I would agree with that. I really like the fidelity model that's used within IPS, so the employment support kind of services, where it's not solely about numbers and waiting lists, whilst they're important. There's something about not what you do, but also how you do it. So a kind of fidelity model that really looked at the what and the how, I think would be really, really beneficial.
Thank you all very much. Norman.
I just wanted to make an additional point. I love what they're doing in Somerset, incidentally, and this point about community organisations. In Lewisham, there's a very significant black population. I wanted to pick up on what Lade Smith said absolutely correctly. People are disadvantaged in those communities, and there is a lack of trust in mental health services. And so for our trial, it will be critical to work very closely with black-led community organisations who have the trust of their communities. And I think if we have to be open to working as equal partners with them, and I think reaching into those communities who are poorly served by the mental health system, not accessing support early, and then overrepresented when it comes to detention under the Mental Health Act. that is an unacceptable feature of the mental health system that has to be confronted, and I think this is the way to do it.
I agree with you. I mean, I would even say that because black people tend to get less access to health treatment generally, less good treatment, less good outcomes, it makes them have less confidence in the system, and there's no surprise about that. So I think the NHS fundamentally, I would suggest, has to do some work in that area,
absolutely.
Not the area of mental health.
There's also a fear, which when I talk to people, there's a fear of that your son or particularly your son might be locked up, and therefore a reticence sometimes to access support early. And why would I go there? I've heard it said. So I think there's an additional anxiety there about the use of coercion and the impact on black men in particular.
Quick follow-up from Jen Croft.
And I'll be very, very brief. Thank you, Chair. So you mentioned black communities. I understand as well that there are a number of learning disabled adults detained in your trust as well as across the country. Have you got measures in place to make sure that they're able to access community mental health care before they slip into crisis mode?
So this is all under something called the Transforming Care Programme, which I actually established in 2012. And the truth is that it has not got people out of institutions as we had committed to doing in 2012. Our trust is the same as most trusts across the country in having people who are in inpatient care who should not be there. We now thankfully have a person whose name is Faye Rice, who is totally committed to getting people out of institutional care and into the community. I linked her up recently with MenCap, who do brilliant work on this, but the the moral case for getting people with learning disability and autistic people out of institutional care is so powerful, and it's a scandal that this persists, in my view.
Thank you.
Very much agree.
Thank you, Joe Robertson.
Thank you. I wanted to look at digital integration and data. I assume there's sort of widespread acceptance that lack of digital integration is a problem, and lack of interoperability between systems, especially for smaller organisations. How do we deal with that?
So I can come to that from a Somerset perspective. So we have, and it's took many years, we have got an interoperable IT system now with our voluntary sector partners and with our GP colleagues. It's Dialogue Plus, so all partners are able to access and see and edit Dialogue Plus, which is the care plan. And we were in the process of celebrating and patting ourselves on the back around how well we'd done, and realised that whilst it's a fantastic clinical tool, it's not a reporting tool, so we're not able to use it to report the incredibly valuable contribution that our voluntary sector make to kind of waiting times and activity and contact rates. So it's a great care plan for a service user to have, which kind of combines all the different elements of their care, whether that's provided by the NHS, by the voluntary sector, but it's not a great reporting tool.
How do you do the reporting?
At the moment, we are doing it by hand. So the mental health data set, obviously, the NHS can do and is automated, but the voluntary sector are doing that pretty much by hand.
It just seems to me a major issue. And when we had Penny Dash here, was it last week or the week before, obviously as the candidate for Chair NHS England, I mean, she acknowledged it was a major problem, wasn't quite sure how to tackle it, because of course these databases are sort of commissioned lower down, aren't they? They're commissioned on a local basis.
I think one of the things that the voluntary sector have said is that if we don't count it, we won't count. And they have a real anxiety that because some of a good deal of their work isn't being evaluated and counted, that they will lose funding.
But isn't this part of the problem why there isn't continuity of care and people are having to have the same conversations every time they move on because the systems aren't talking to each other and aren't passing those notes along?
Yeah,
I mean, I do think this is a real issue, and having gone out and visited services and talked to colleagues working in them, this is definitely sort of one of their top 3 issues that they are grappling with. And I think also, again, listening to Eve this morning and the other testimonies that have been given to you in evidence, the sort of having to repeat one's history continuously, it's not good. It's not a good experience, and it's also got not a good efficient use of time either. If we look at productivity across the service, we have, I think, been able to start to crack this in some pathways of care. So maternity, I think, is a good example where Badgernet, and certainly in our ICB now we have full coverage of Badgernet. So if you're going through the maternity pathway, there's a really single digital record. There are still issues around digital inclusion, and I think particularly from a user perspective that we've got to work with to overcome. But where this has worked, it requires dedicated resources and I think a kind of a real focus is what I'd say. I think the other area we've still got some work to do is around sharing information and the governance related to that. So I think through partnerships and working in the best interests of patients and using their information, we try to prevent governance and the bureaucracy of that getting in the way of that. But if there, again, I think, was some clearer guidance or use cases for how patients' data would be used across a pathway where you've got multiple interfaces with different providers, that would be helpful.
I just also wanted to mention something that doctors at the Maudsley and the Institute of Psychiatry, Psychology and Neuroscience have developed. They call it LUCI, L-U-C-I, can't remember what it stands for. And we can provide more information if you want, but it allows you to analyse your whole patient population to understand where the hotspots of psychosis perhaps are across your boroughs, so that you can then target your work more closely. It allows individual clinicians to identify people who may be attending A&E more often and so might be at risk of falling into crisis. So I think the combination of digital analysis with a more humane approach that hopefully you'll see in Trieste, but is also present in places across our country, is the real answer. When they presented to the board, though, I asked them what was the one thing that could make it more effective, and they said being able to access information beyond the NHS, because the only data they have is NHS information, and yet so much of what affects these people's lives, housing, employment and debt and so forth, lies beyond the NHS. And so bringing data together could be a real game changer.
So thinking about not necessarily interoperability of systems, but the lack of data about mental health as opposed to physical health. I think at our last session that was identified as a factor in that lack of parity. I mean, do you see that we have a particular lack of data in mental health as compared to physical health, and how do we go about gathering that data?
I can speak from the perspective of being a provider that's an integrated provider. So Somerset Foundation Trust is an provides the acute community and mental health provision within Somerset. And one of the things that I am really aware of is how much data there is in acute physical health care compared to, and not just the amount of data, but the quality of that data, and how, probably best put, how poor the data is that's available in terms of mental health. And that's around holding us to account, as well as being able to really monitor what's going on within our local population.
We fatally neglect the physical health of people with significant mental ill health. I totally agree with Lade's point about the training of our nursing workforce. And there is also a lack of rich data on the people within our organisations who almost always, amongst older people with mental ill health, it's almost 100% comorbidity, but even with working age, the percentage of people who have comorbid physical ill health is very high as well, and yet we're not providing holistic care.
I have a slightly different sort of view, which is actually, I think we're awash with data. I think there's a huge amount of data out there. I can look at our population. We've just developed our clinical conditions strategy where we can drill right down into the GP record. We can look at the diagnosis. It's the quality of the data, and it's also the extent to which there's the analytical capacity and capability in order to focus on it. And I think where we've got inherent bias in the system that inherently places a bias on the physical health side, where we have teams of clinical coders, we have a payment by results approach, your data quality is going to be slightly better than it is when you're looking at your mental health conditions, looking at prevalence and understanding what's actually going on in services. And I think also we've got, and again, I think this has been drawn out by some of the lived experience examples. If you are going on a pathway to hospital to have an ankle operation, a foot operation, a knee operation, you could be going for cancer care, and you could have different pathways for different tumours. We don't have that level of sophistication in the treatment pathways that we're commissioning and are available at the moment, because quite simply there's a gap between the treatment that's needed and the resources available to support it.
Thank you very much. Josh Fenton-Glynn.
Thank you. So I'm going to just move on a little bit to the kind of funding models and kind of the way that we're looking at funding now, because one of the things that came out in the Darcy report is that in terms of community mental health, we're way down. I think we're 86% lower, if I remember correctly, than the OECD average. What do you think the ideal model, the kind of good model of funding NHS services looks like? I'll leave it to all of you, but maybe I'll start with Samantha, obviously with your ICB hat. Okay.
Well, I'd start with the point I made earlier, which is I think that funding allocations need to be fair. They need to be based on the need that exists within the population. And I'm not a funding expert, by the way, but there are a number of ways you can look at that. And you can look at the size of the population, you can look at the age, the demographics, and then, of course, the sort of social economic need that sits within the population. As I set out earlier, the population that my ICB serves has high level of health inequalities, high levels of poverty and socioeconomic needs. So my view would be a fair funding allocation should be one that supports that population fairly. And at the moment, it doesn't. Yeah. We are stuck in what we call the sort of quadruple whammy, where our population sadly lives a shorter period and lives longer years of life in poor quality health. And because the funding formulas at the moment favour an ageing, growing population, which we aren't, that isn't fair. So for me, the premise of funding allocation, it needs to be fair. And I think that whilst we can have really outstanding healthcare services, actually the true left shift needs to address some of the more wider determinants. And some people may say they don't understand what housing has got to do with healthcare. Well, when you've got 2/3 of your children living in poverty, they've got high respiratory needs, they're of course going to be your highest attenders at A&E. Well, good quality housing is one way of addressing that, and I could go on.
The former iteration of this committee did a report on exactly that.
Yeah, and there was a big section in Darcy on social determinants of health, and I think that that is a debate that we definitely need to have. So Norman, what would you say?
Well, I was just going to say quickly, before the session, we talked also about multi-year settlements. At the moment, these single-year settlements are disastrous. It makes it impossible to plan anything. So I think that's important. Totally agree about addressing the sort of social determinants of health. So much of it relates to the work of local authorities, and we quite often have problems discharging people because there's a lack of resourcing of good quality supported housing, for example.
Can I push you a little bit, Norman? So if you had your time again and you had the chance to control the service back in 2012, how would you have devolved it differently?
Well, I think through these years from 2010 onwards, local government has been cut too much. I totally agree with that. There's always a temptation whenever money is tight to cut the preventive end of the spectrum. That's what we just repeatedly do. And yet it's the most stupid thing to do because it's the way of avoiding people falling into ill health in the first place.
I think Lade had some figures about the number of hospitalisations and A&E visits in the last session. I think she said 17% higher, but don't trust my stats. But I think that's a very key thing about getting this right, is if we get that.
But I would also say, incidentally, developing much closer health and social care collaboration. We haven't actually had integration between health and social care, and I would like to see ultimately a health and social care service in localities that are joined together with pooled funding.
So the next thing I just want to follow up is obviously with the ring fence of services kind of going, is the investment standard the best way to fund community mental health, or would there be a better model you'd suggest?
I think the mental health investment standard has been a way of ring fencing, and it's been an effective way of protecting money for mental health services. I would agree with my colleagues that we need to think about using that money across the system and be thinking about the wider determinants and outcomes-based commissioning. And I'd probably want to put a bit of a plea into thinking about the application of funding in rural, coastal localities, where there can be particular challenges around that kind of local infrastructure.
I mean, having, recovering local government officer in a semi-rural area, I'd strongly, agree with that. I'll pass back to the chair.
Thank you. So I'm going to ask you guys the same question I asked at the end of the last panel. We've got the 10-year plan coming. What would you like to see in it as a top priority? Can I start with Sam?
Two things: no silos, and a true joined-up, integrated neighbourhood service.
Okay, give me one more sentence under each of those headings. No silos. What do you mean by that?
So, see people as people and address their physical and mental health care together where you can, within an integrated team that's got access to the full range of specialisms that are required to do that.
Anything else? No? Jane?
Hardwiring system leadership and having that as an approach to neighbourhood mental health. I think waiting times needs to be in there in order to make sure that we've got the right parity of focus. And I would also want to see the role of the voluntary sector and co-production recognised.
Hardwiring systems leadership. Yeah. What exactly do you mean by that?
So I mean there being systems to support local and almost force, although that's probably not the right word, the local authorities to be working alongside the local NHS, primary care and voluntary sector, so that the design, implementation and delivery of services is done by the system.
And what would that look like? What does that mean for the 10-year plan? What's central government's role? That force is a word. Let's use it. So what should be in there to force the system to do that?
I think it will be having those waiting time targets.
Waiting times targets.
I think that will be one way, because that's a symptom, isn't it, of that things aren't right, that mean that you have to, as a system, look together at how you resolve that.
Thank you, that's very helpful. Norman?
So first of all, I mentioned the investment in the community infrastructure. I think it's critical. There will be places where you can use existing community facilities, but other places where new facilities bringing together local government, mental health, third sector will be critical. And using innovation, not just relying on the Treasury, but innovative approaches. Secondly, 24/7 support centred around community centres in the Trieste style. it actually brings together a lot of things where there is a clear evidence base. Lade talked about the continuity of care, which simply doesn't exist in many cases under our current arrangement. That needs to be a central element, so you base it on building relationships with people and continuous care. I would also make a plea for personal budgets for people with mental ill health. It's been developed in local government brilliantly, and it's a way of transferring power to people so that their priorities count. It's used in Trieste. They then use the money to invest in third sector to provide the sort of support for people. Sorry?
Work? Roll that down a bit.
So a personal budget is agreed between the individual and the professional. It's a joint.
And they buy services from third sector.
Then they buy.
I see.
You'll see that there's quite a culture of sort of cooperatives in a locality, which then employ people. Which employment is critical. Gives people a sense of self-worth and dignity. And we know then that they use services less when they're into employment, provided it's good employment. So those, I think, are the things that I would particularly focus on.
Thank you very much. Norman, you're retiring from your role.
I am.
At the end of the month. So I'd like to offer you a parting shot to the government/NHS. I mean, from where you sit now, having, is it poacher or gamekeeper being the minister? I don't know which one. And then you've moved into this role, and now you're moving on. Can we have just the benefit of your wisdom and experience? What would you say to them as they are looking to retransform these community mental health services? What do they need to focus on? What's your message to the ministers?
I've gone from talking the talk to trying to walk the walk, and it's a lot harder in the NHS actually doing it. So I would say, first of all, don't lose the increased priority that's been given to mental health. I agree that the mental health investment standard has been an important way of protecting mental health. I would actually have some conditionality to it. I would say that it needs to be used to invest in the change to a different, the sort of systems that we've been talking about today, rather than just going into a black hole which maintains a dysfunctional system, which I think is a real risk. But I would say grasp this opportunity. There's an increased interest around the country. You've heard examples of really impressive approaches around the country, Somerset, North East, Cambridgeshire, the trials of these new models of care. Within these, we can see the emergence of a mental health system that is more humane, that is much more focused on preventing deterioration of health in the first place, that recognises that we have to confront the social causes of ill health, which largely we ignore at the moment, and we have to bring physical and mental health together. Somerset is the only integrated system, I think, in the country, an organisation that has both acute hospital and the mental health system, so they actually start to talk to each other. I think there's still a long way to go, you would say, but I think this sort of artificial separation of physical and mental health has actually been quite damaging, and I think we managed to fatally neglect the physical health of people with mental ill health, but we also neglect the psychological needs of people who have physical health problems as well. And it's what an irrational way to behave. We don't offer holistic care. And so I think there's a lot of despair in the mental health system at the moment. I think staff feel that they're working in a system that is constantly under stress. Everything is full up, people being sent out of area in the most appalling way. I mean, this is a disgrace, people being sent to hospital beds 100 miles away from home or whatever. It should be completely outlawed. And so you sort of have a sense of a system that is stressed and not working effectively. But I think the exciting thing is that we can see that there is a route to a better approach, which will actually be more effective at keeping people well, avoiding people falling into crisis, and actually ultimately will be more financially sustainable.
Lovely. Well, thank you very much. I'm not sure we can. Eve.
He's up next to him.
Would you like to just come onto the panel 1 second? Having heard everything you've heard today,
yes.
Have you got any more reflections?
I think it's a reflection that I had when I went to the Labour Party conference this year as well. And I think that there's so much well-meaning and so many people who know what the issue is and have the insight to be able to change it, but that it feels like there's a blocker. And I don't know what that blocker is. And it's big picture, and all of these things interconnect as well, with, you know, like the social and the cultural. But that, yeah, there's a big problem there that feels like it's like a rock that you want to kind of chip away at. And everybody knows what it is, and everybody wants it to be fixed, but it's not yet been.
Yeah, I agree.
What would be what my thinking is.
Well, thank you very much. That's what we're trying to do. Thank you very much to our third panel as well. That was very illuminating. Order, order.